Thank you for giving all the love and support to my channel. Today we'll go into the mysterious world of anesthesia.
I always say this, and I think you should mention this. If you're a good anesthetist, your patient will not remember you.
That's going to be your tagline.
If you've done your job properly as an anesthetist, they're not going to remember you. Are you a doctor?
Oh my God.
Also, a very common question, are you going to be doing the surgery? I'm like, no.
Right.
I'm putting you to sleep. I'm keeping you safe when you're sleeping, and I'm waking you up. And I'm making sure that you're pain-free after surgery.
Right. Hello, and welcome to the Health Talk with Dr. Sagorika Mullick. Today, we are pulling back the curtains on one of medicine's most fascinating specialties. While surgeons take center stage, there is an equally crucial expert in the operating room, the anesthesiologist. They are not just the doctor who puts you to sleep. They are your guardian angels throughout the surgery, managing your pain and vitals and ensuring your safety. So joining us today is my good friend, Dr. Sunita Pillai, a highly experienced anesthesiologist who will help us understand this vital medicine specialty and answer questions that many of us have been too nervous to ask.
Dr. Sunita Pillai is a consultant anesthetist at the Lancashire Teaching Hospitals, NHS Trust, UK. She has done her graduation and post-graduation in anesthesia from Grant Medical College and Sir J.J. Group of Hospitals, Mumbai, and later did her fellowship at the Royal College of Anesthesia, UK and Ireland. During her younger days, she used to sing jingles for advertisements and was the lead singer of a rock band during her internship period. Nowadays, though, Dr. Sunita is an extremely private person. She loves animals, enjoys reading and traveling the world. She is an extrovert turned recluse who now enjoys her me time. She does not believe in any kind of social media presence, so I consider myself really lucky to get my friend Dr. Sunita Pillai to my podcast, The Health Talk.
Welcome, Sunita.
Hi,
Your
Agust. Good to be here.
Good. Right, Sunita. As I said, people know a lot about surgeons, but they don't know much about the anesthesiologist. So why don't you just walk us through that what does an anesthesiologist actually do before, during and after surgery?
Okay, first place, Sago, the main thing is it's an extremely underrated specialty.
Absolutely.
Okay, and in fact, even in a developed country like where I am, I still have patients from a certain class who say, but are you a doctor when I go to see them?
Right.
Okay?
Right.
I mean, of late, thanks to Google and everything else, it's become a lot less.
Right.
But I still have it.
Right.
Okay?
You still get those questions.
I still get those questions.
Right.
Okay?
Right.
So that's your basic.
Right.
I mean, that's the common man's understand. And are you a doctor?
Yeah.
So starting with the pre-op, some
Right.
of them come up with this question, are you a doctor?
Right.
So then I have to tell them very gently that yes, I'm a doctor and I've been doing this as a consultant for 20 years and another 10, 12, 15 years before that.
Right.
Okay. Now, the next question was what do you do pre-operatively, intraoperatively, and post-operatively? Let's start with the pre-op.
Right.
Okay. Now, I don't know how the systems work in the rest of the world because I've exclusively worked here.
Right.
And my India experience was a different ball game
Absolutely.
altogether.
Right.
Okay.
Right.
Here, what it begins with, once surgery is decided, etc. The system, the way it works is they go through first the pre-operative nurses. These are nurses who are trained for pre-op assessment. Okay. So they go through all the routine questions. It's like a spreadsheet
Kind of a questionnaire.
and they go through everything. And if they flag up anything or anything that they're not sure about, they even look at an ECG. Anything slightly wrong in the ECG is flagged up, okay? Anything, whether it's investigations, anything that's flagged up goes for an anesthetic review.
Right.
Now, anesthetic reviews in this country, recently, it's become rather organized. So if you're having neurosurgery, you go to a preoperative anesthetist, a consultant who does neurosurgery.
Right. So
Okay.
you're specialized mainly in neurosurgery.
Yeah,
Right.
that's just one example.
I
For
understand.
example, obstetrics,
I
they
understand.
will go to an obstetric if it's flagged up.
Right. Understood.
Okay, a fit and well patient is not, the nurses, they put everything down and there's no need. But the minute they flag up something, they're referred. The next step is the patient goes and meets.
So there the doctor steps in.
Yeah, the doctor steps in. May not be the person who's actually giving anesthesia on the day,
Yeah.
but it will be someone who does the same anesthesia.
Somebody from the team. Somebody from the team.
That specialty.
That specialty, right.
Okay. So once they have gone through everything, what the nurses have flagged up, then they decide, maybe this patient needs post-operative ICU care, HDU care, whatever, and they make their comments. But on the day, it's me who's putting the patient to sleep.
Obviously.
So I have to make the decision, but it does help because there are colleagues who you worked with and you know.
Right.
So that's your pre-operative. Baseline is taken care of. Again, everything is IT based now. All what I'm talking about, the nurse's assessment, the anesthetic pre-op consultant's assessment, everything is IT based. So it's all on the computer.
Right.
Okay. So pre-operatively, I go through everything that's there.
Obviously. Yeah.
Including your investigations, whether it's ECG, pulmonary function tests, echo report, it's all there. Okay, so you go through everything. Now, as far as me meeting the patient, these all things have to happen before you bring the patient to theatre. It comes to the anesthetist who's actually going to put the patient to sleep.
Absolutely.
Okay? In the old days, 20 years ago when I came, the NHS was not like it is today.
Mm-hmm.
Okay? We had beds in plenty. The population was not aging.
Right.
Since it's an aging population, there's more and more comorbidities, etc.
Right.
On top of that, weather being what it is here,
right,
like winter pressures, is something that's real. It's not unreal. Okay,
right.
Because you have an aging population with occupying beds, which pneumonia, respiratory infections, that kind
Absolutely.
Yeah. So that is a factor. So, like I said, in the old days, 20 years ago, I could go the previous night into the ward at about like 7:30, 8 o'clock in the evening. The patient's admitted, everything is done. Okay?
Right.
And you can go and sit and chat, and they have a relative with them or not with them, whatever.
Right.
Have a detailed chat with them. Next morning, you come to theatre, you don't even have to see because you've just seen them the night before. They come directly to theatre. And of course, you always mention if there's anything you remember, you ask me.
Right.
Today it's different, as in the patients come in the morning.
Okay.
Okay, because of this bed situation.
Bed situation, right.
Okay, in the country. They come in the morning, which is why those days they didn't have the IT.
Right.
It was all
handwritten
notes. Okay. But now, I guess, make up for that lack of knowledge from the writing staff, it's on IT, which some ways is better.
Yeah.
Okay? Unless your grooming password goes down, then you have it.
Right.
And it does happen.
Okay.
No matter.
All right.
Okay?
So that's the peril of technology also.
Yes.
Yeah.
Okay, there's positive and negative.
Absolutely.
So then on the morning of the surgery, you go and meet the patient. You've gone through their notes, so it becomes a lot quicker because you don't have the time the previous evening, right? It becomes a lot quicker. So speak to them and you say, look, I've gone through all your notes and everything, your assessment, everything. Now let's just confirm all these things that I've got written down here.
Right.
And we go through all the things and they say yes, no. And if there's details, like they say, the nurse said he had a heart attack. So what was that all about?
Absolutely.
Did you go into hospital for that?
Right.
Did you have a stent?
Yeah. So any other details which you want to know about, you can ask them. But basically the patient is already prepped up also mentally.
Yeah, and also I forgot to mention, pre-operatively, especially for major surgeries, they're given a booklet.
Right.
At their first consultation.
Right.
Which explains everything about, the anesthesia, the surgery. Most of them don't read it because they don't want to know.
Right.
I'm saying 50% do, 50% do.
Understand. Yeah. People are generally scared.
The downside is the ones who do read, they come up with 1,000 questions. And you have Google, our friend.
Yeah, absolutely. So what do you think? What is better, a patient with 1,000 questions or a patient with no question at all?
Patient with 1,000 questions.
Right.
100%. So this is all we're talking pre-operative. Then we go through exactly what we're going to doing because medical legal system being what it is, exactly, even rare things we have to mention. And we have charts where we tick the box. We tell them straight, look, anyone who gets an anesthetic needs to know these things. I've got to tick the boxes, I've got to tell you, and you've got to sign it.
You're right.
That I've told you.
You're right.
And literally, I go through ticking the boxes. Like, it's common to get nausea, vomiting afterwards.
Right.
Common to get a sore throat afterwards, depending on the anesthesia.
Type of anesthesia.
On the type of anesthesia. So all that is done. And then, of course, you always tell them, if you think of anything before you come to theatre, please feel free, because you'll be awake when I see you in theatre.
Right. Right.
So that's your preoperative, generally,
Right.
in short form.
Right.
Not short, but whatever.
Fair enough.
Okay.
No, I think it's good that you have given all the details.
Yeah.
That is important.
Okay.
People to know
Yes.
what exactly you do.
And not to mention, then once they come to theatre, there's these pre-op checks which are done on the ward. They are done in theatre. They are done after the patient's asleep. There's WHO guidelines.
Right.
Okay, they call it a checklist. And before the patient comes, we do which has also come because of WHO, a time out. Time out means the surgeon is there, the anesthetist is there, each and every staff member who's going to be in that theatre is there. Okay? All introduce themselves so they know what each one is doing.
Right.
We go through each case in detail.
Right.
There's like a whiteboard kind of thing. Everything is gone through, including what comorbidities they have. Everything is gone through. Surgeon will have to tell you how long the procedure is likely to take. Anesthetist has to tell you how long it's going to be for the anesthesia, because it varies from person to person.
True.
How long the positioning is going to be, if it's, not
particular position needs to be,
Okay. So all this is done and it's signed off, and then only they can proceed with the surgery.
Fair enough, but how long all this whole procedure, how long does it take?
This is the thing. Now, these are essential things. It happens everywhere. It's compulsory. There's no option.
Right.
Okay? Because you have management sitting on your head. Not only management, you have the national
from the safety factor also, safety point of view also for the patient.
For the patient.
Right.
Okay? So all that is done, and then finally it comes to the intraoperative management.
Right.
Okay? Now, because of this business of patients coming in the morning of the surgery, pre-medication has become a thing of the past.
All right. Okay.
Because previously you could prescribe like 5 o'clock in the morning, they
Right.
the ones who are very anxious, whatever,
Right.
you could prescribe it the night.
True.
Now it's not. At the most, you have people with special needs, in which case when they come in the morning, immediately the anesthetist prescribes, especially children.
Right. Right.
Okay?
Right.
But it has become a lot less as compared to before.
Right.
Okay? They come into theatre, all these checks are done, everything, you reassure them. And you have some of them who are, do what you like. I don't want to know about it. Don't tell me anything.
Don't tell me. Right.
But we generally tend to explain to them what we're doing, right? We're going to put in a cannula now, there's going to be a sharp scratch. These are all routine monitors, everybody gets them, because we need to keep an eye on your heart, your blood pressure, your oxygen, saturations, etc. Everybody gets them. Some of them don't want to know. Some of them in great detail want to know.
Right.
And some of them fortunately are in between,
Right.
Seriously.
I think
These are the nice ones. And then you get the ones who are very tearful, and you have to tell them, look, if you go to sleep crying, you're going to wake up crying, and I don't want that.
Right. Nobody wants that.
Reassure.
That's what you have to keep.
Maybe a little squeeze on the hand. Don't worry, I'm looking after you. I've done this for yonks.
Right.
Now, and generally you calm them down. Now, the anesthesia itself is very different. There is no one size fits all. Not in any form of anesthesia.
Absolutely.
Is there one size fits all? Okay? Maybe like surgery. One appendix may be high up and the other one may be,
Absolutely. So
it's like that.
Totally individual thing.
And it's a total individual thing, and the anesthetist is the one who has to decide.
Yes.
The surgeon sees the appendix and he knows it's high up, high, low down, whatever. And he plans his thing after he sees it.
Accordingly.
Here, we have to decide our plan of action, which is a very important thing.
Yes.
You've got to have a plan A, plan B.
Right.
In the back of your head, you need a plan A, a plan B, sometimes a plan C.
Right.
So that's your intro. Like I said, one size doesn't fit all.
Absolutely.
Everyone is different. The kind of anesthesia you use for different cases is different.
Yeah. Obviously, intra-op is you're giving an anesthesia. Whatever type of anesthesia is there, you're giving an anesthesia so that basically the patient doesn't get the pain.
And not awareness.
Awareness.
Okay? No pain.
No pain.
There's, depending on the surgery, muscle relaxation if it is required.
Absolutely.
Okay?
Right.
And most importantly is the safety of the patient.
Absolutely.
You've got to be maintaining your baseline. Okay, some surgeries you need the blood pressure down.
True.
Some surgeries, okay, you need the blood pressure up when they
Yeah.
want to perfuse, whatever.
Yeah, but then
All
again,
that
everything
is tailored to each patient.
Each patient's
There
need.
Yes.
Yeah.
Okay?
Yeah.
And also how they react.
Right.
The way the patient reacts to what you're doing to them,
Right.
you have to react to how they are reacting.
Right. So that's the reason you have all those plans. Plan A, Plan B, Plan C and all.
Exactly.
Right.
Right. So as for post-operatively, another ball game. It's mainly all about pain relief and where the patient goes to a safe area for them.
Right.
You might be having like a fit and well patient who comes in for like a routine surgery. They are not doing very well under anesthesia. You bring them out and everything, but you feel okay, this is not fit for a day case, and they need to go for a ward overnight. They can go home in the morning,
Right.
just for their own safety.
Right.
And frankly, our safety also.
Yeah, of course. I mean, see, your safety is from the medical legal point of view.
Yes.
That's a totally different ballgame. But main thing is
the
patient safety. So that is what
that's it basically.
Right.
So you decide.
But how difficult is it to bring out a patient from it? Because that is what many people have an issue. Like
will I wake up?
Will I wake up? I mean, will I wake up in between surgery?
That's
will I get the pain? And how do I wake up post surgery? What will happen?
Now this is a question that I'm asked. But how do you wake me up?
Right. How do you wake a patient up? You put a patient to sleep with drugs.
Yes. Okay. Similarly, there are drugs you use. You turn them off.
The previous drug.
No, the ones which keep them asleep. See, anesthesia, you've got to put someone to sleep.
Right.
You've got to keep them asleep.
Right.
You've got to wake them up.
Right.
And you've got to keep them pain-free after they wake up.
Right.
Okay?
Right.
These are the basic tenets of
anesthesia.
Right. Okay?
Right.
So this is the thing they ask, but what if? So I say, look, the way we put you to sleep, the same way we reverse the process, that's the simplest way to explain it.
Yeah, obviously. That's what see. Then here also we are talking about something which a layperson will understand.
Exactly.
So that's why how would you tell a completely lay person who's a patient that
how will you wake me up?
How are you going to wake you up?
So I say, just like I put you to sleep, all the things that I do to put you to sleep, one by one, I take them off you so that you wake up.
Right.
So this is a very common question.
Yes.
Actually, is the other one about, I've heard that people can be awake.
Right.
Which is awareness.
Yes.
Now, awareness is known to occur. It's 0.2 to 0.4% at the last thing I read, okay?
Mm-hmm.
That means 2 to 4%, 2 to 4 patients per 1,000. Of course, it veers towards the 4 per 1,000 in certain cases like post-traumatic stress disorder. They are more obstetric anesthesia where you have to use a lot less because of the baby.
Exactly.
Those are towards the 4 out of 1,000.
Right.
But generally, it's 0.2. This is a question that's asked always. And like I said on my tick chart, tell them sore throat, nausea, vomiting, a bit of delirium after surgery, headache, all this. One of them is anaphylaxis, which is very important.
Absolutely.
Okay, so they need to tell you very clearly if they are genuinely, of course, they like today I had someone saying I'm allergic to paracetamol. Okay.
Yeah.
You're allergic to paracetamol. What happens? No, I get some diarrhea with it.
It's a big problem. Many patients don't understand the difference between a side effect and an allergy. So, many patients tell me also that I'm allergic to so and so.
Yes.
So, then I have to again, as you said, ask what happens. What happens? So, true.
And some of them will tell you, I don't know, but I was told I'm allergic.
Right. So, you just have to
use caution there.
Yeah, exactly.
So that's what happens intraoperatively and then waking them up. Okay, and all goes well, which it normally does.
It normally does.
It does because anesthesia is advanced and we are so careful now.
Of course.
Which we should be.
Finally, everything is ultimately patient safety.
Exactly.
Even to give a simple paracetamol, also we have to say that you can develop an acidity, you can. So it's whether it's an oral drug as simple as a paracetamol or as anesthesia. Okay. Right. So you are a neuroanesthetist, I know.
Yeah, I've been a neuroanesthetist. Talking of that, being a neuroanesthetist. Today, at least in this country, anesthesia is extremely subspecialized.
Subspecialized.
I had to do an extra 1 year after my full training here in neuroanesthesia because that's what I wanted to do.
Right.
Similarly, they have either diplomas or degrees for cardiothoracic anesthesia, upper GI anesthesia, vascular anesthesia,
You're serious.
lower GI anesthesia, obstetric anesthesia, and the list goes on.
Okay.
Okay, now today, back home in India, you gave me a vascular patient, you gave me a baby, pediatric anesthesia.
Pediatric anesthesia, yes.
Okay, you give me a baby, you give me some vascular patient, you give me an orthopedic patient. I will do it all.
Right.
Not anymore.
No.
I won't.
You won't.
Because things have moved on.
I understand.
And if you're not competent,
You're right.
you may be competent in one particular specialty which you're doing day in and day out.
Right.
If you're not competent, you're welcome to refuse. Like if somebody calls in sick and your list goes down or something,
I understand.
and they say, can you go and do, obstetrics,
Right.
the sections, the
Right.
electives,
Right.
I will say no.
Right.
And in fact, they don't ask me.
Understand. But in India, I think it's still not so much of subspecialization is there. I mean, I'm sure it is there in the big corporate hospitals.
Yeah.
In the smaller nursing homes, or of course in the village areas or in the smaller towns.
Yeah.
We still have one anesthetist who would be handling all types of cases.
Yeah.
All types of cases.
But then here it's become like I'm in a teaching hospital.
You're right.
Okay, it's a tertiary referral center,
Absolutely.
which is why we have all these specialties.
Absolutely.
The downside of that is, Sago, previously, without a care in the world, I could put a neonate to sleep.
Right.
Today, I won't even enter the room.
Right.
No question.
No question. You maybe
So, certain bit of de-skilling, you know what I mean?
stand, but I mean, it's like you're knowing more and more of less and less kind of thing. But
Absolutely.
so,
That's very well put.
So that's what. I mean, see, if you have the people power, to have those subspecialties, it's fine.
Yes.
It's fine. But in places where they don't have the luxury, I would say, to have those subspecialties,
Yes.
then they will have to obviously.
There are hospitals here which are small district general hospitals
Yeah.
where, again,
Right.
but they're not doing the major stuff,
Understood. Totally understand that. So that's what I said. It depends on which part, where are you placed.
Exactly.
Whether you're in a tertiary care or in a primary care.
Exactly.
Completely different ballgame.
If there's something major, if they have they will refer,
Which is totally understandable. Yeah.
So you do get a little bit of de-skilled. At the same time, you get a lot of skills in
your specialties. Yeah.
You can handle anything.
Again, it is like, finally patient safety.
Yes.
You're right. I know you're a neurospecialist, but I'm sure you will be able to tell us what are the different kinds of anesthesia which are generally used,
Okay, like I said before,
Right.
it's a very underrated specialty.
Right.
Some surgeons realize that we anesthetists are like termites in the hospital. We are crawling everywhere.
What a statement to make.
Okay?
Right.
Which is a fact, son. People don't realize. We don't just put people to sleep and wake them up and job done. No.
You're right.
Okay? It is not that.
You're right.
I'll be very honest. The A&E department calls us. The ward calls us. All cardiac arrests we are.
Yeah.
Pediatric cardiac arrests we are.
Right.
Okay? Anything happening anywhere, anesthetist is port of call because they know everything. Physiologically.
Exactly. And that's what I was trying to tell everybody that, any kind of emergency,
Yes.
it is the anesthetist who's called first.
Yes.
Because they know how to manage an emergency.
When I joined, like 20 years ago, it was anesthetists who used to handle intensive care.
Right.
When I was doing my training, proper training, I was doing anesthesia, but some nights I had to do a block of intensive care only.
Right.
Okay, that has changed. Now that is intensive care medicine.
Yeah, we do have intensivists nowadays.
Yes.
Separately. Again, as I said, Sunita, it is at which level of care you are in.
Yes.
So I'm just trying to understand that you just forget that you're a tertiary care anesthetist.
Yes.
Okay, suppose if it's in a primary care setup.
Okay.
Okay. So one anesthetist will be handling so many things.
Yes.
As you said, they'll be giving anesthesia, they'll be handling all kinds of emergencies, whether it is a cardiac arrest or whether it is
anything that comes into A&E,
anything.
Intubation.
Yeah. So that's what. So then, what are the different kinds of anesthesia an anesthetist needs to know? Like, or what are I've heard like general anesthesia or a spinal anesthesia.
Yeah,
so,
let me tell you.
Yeah.
So, like I said, remember everything is specialized now.
Understand. Right. Yeah.
Okay, so there's basically local anesthesia.
Right.
Which is normally administered by the surgeons.
Right.
Of course, they ask us how much, the safe amount of anesthesia.
Of course. That's very small
procedures.
Right. Very localized procedures.
Okay.
Right.
Then you have regional anesthesia.
Right.
That is your peripheral nerve blockades.
And those are used for?
Supraclavicular block, shoulder block.
Okay, but what are generally used for? Like
orthopedics mostly.
Only orthopedics. Okay.
Mostly orthopedics, sometimes plastics.
Okay.
Right. When they're doing hand surgery, etc.
Right. Okay. So then you don't need the whole body to be anesthetized.
No.
So then that's the reason you're giving them.
At the most you give them a bit of sedation, which I'll tell you about later.
Right.
Okay, so that's regional anesthesia. Then you have your central neuraxial blockade. That is basically your spinals, epidurals and caudal epidurals.
Okay, and those are generally for neck.
Epidurals mostly for post-op pain relief, for the major GI stuff. Upper GI, lower GI. You have your thoracic epidurals and lumbar epidurals with a catheter in for 24, 48 hours post-operatively.
Okay.
Also used in obstetrics, as you know. It's all spinal and epidural.
Right.
They try and avoid GA for the simple reason that awareness is more of an issue.
Yeah, I didn't know about this thoracic epidural.
Yeah, thoracic epidurals, they do it.
I'm just trying to understand what are the different types.
So then you have the neuraxial blockade, central neuraxial blockade, that's your spinal epidurals, etc. Finally, you have your general anesthetic.
Right.
Usme bhi there are two. There's either an inhalational anesthetic, where you use gases like sevoflurane, desflurane. Like I told you, you send someone to sleep with drugs, you keep them asleep with either gas or intravenous drugs continuously. That's something known as TIVA, total intravenous anesthesia, which certain things it is required for. You cannot use gas.
Right.
Okay. So it's either a gas anesthetic or it's a total intravenous anesthetic.
Right.
Again, I can't say, isko gas do, isko. No.
Right.
I can't do that.
Right.
Like I said, it's individually tailored. And also depending on what surgery is going.
Yeah, of course.
Yeah. So that is what anesthesia is all about. And then we have the ultimate nightmare, which is called sedation.
Why do you call it a nightmare?
Because sedation is when the surgery can be done under a local anesthetic.
Okay.
For example, ophthalmic surgery, which I do. I do this as a rest and relaxation day. Ophthalmic surgery.
Right.
That's my R&R day.
Okay.
Compared to neuro, which I'm doing all the time.
Obviously. Right.
So, and unfortunately, I do oculoplastics.
Okay.
So, the surgeons, they'll prefer to do with local.
Right.
The ophthalmic surgeons. But they'll say, Sunita, it will be nice to give this one a bit of sedation, and my heart sinks.
Why?
Because, like anesthesia is tailored, sedation is even more difficult. It's much easier to put a patient to sleep than to give sedation. Because each one reacts differently. Either they are too awake or they're dead asleep, in which case, and because you're not intubating them, you're not having any airway support.
Right.
They bloody stop breathing, then what do?
That's a serious problem then for you.
So, sedation for me, to get the balance right.
So, it's obviously you're saying it's a nightmare because finally how the patient is reacting.
There's no recipe.
Right.
So then the snoring and the patient says, see, they're snoring so much that their head is moving. And Baba, I would have given a general anesthetic.
Right. That would have been easier. Right.
So there you go. Of course, opthal patients, I do understand, even for me, because they are old, like I said, aging population, they're ancient. And I'm not being ageist, But along with age comes a whole lot of coworkers.
Absolutely. Yeah. As doctors, we are least bothered about the age as a number,
Yeah.
It's basically what it brings with us. What kind of other problems which we need to keep in mind.
Exactly.
So that is something, and especially, as an anesthetist, when the patient is completely under your control,
Exactly.
you have to be extra careful.
Yeah.
So obviously you need to
So, like I said, it's tailored to each one.
each person.
You're
Right.
So,
So, Sunita, you have told us what kind of anesthesia and how and which patient may be given what type of anesthesia and what all safety measures you have to take care of, before giving anesthesia to your patient. So, I wanted to know that, do you want to tell the people that there are certain things they should tell the anesthetist before the surgery? For the point of view.
Sagu, I think I've mentioned this earlier.
Yes, but
They need to tell you, even if they've got a chest in. I've got a slight cold for the last 2 days.
right.
That's chances of post-operative respiratory complications.
Yeah, because
right?
many times patients say, "Oh, I didn't realize the importance of this. I didn't think this was important enough to be told." So that's why, do you have certain questions or checklists?
No, like I said, they do their pre-op assessment. If they need to, they're seen by a pre-op anesthetic consultant. But on the day, they may be having a chest coughing up green phlegm.
Right. Then you will not do the procedure.
Yeah, if they hide it, you're stuck. You can't do anything about that.
Right.
But the thing is this allergy business. But it's better to know that I'm allergic to paracetamol rather than not know about it.
Because you never know if somebody can throw an anaphylaxis.
So, like I said, you go through all the IT stuff on the computer and what your previous consultant has assessed, etc. Then I go through all this with them, ask any details. Are you okay? You had a heart attack. What happened? Did you come to the hospital? Were you in intensive care? Did you have a stent? Did you have a bypass? All this I ask. Normally it's picked up in pre-op in every case.
Right.
After all this, my last question is there anything at all you feel you need to tell me about anything medically related to you?
Right.
This is always my last winding
question.
Is there anything that I've not mentioned?
Right.
That you need to tell me about?
Right.
Sometimes they'll come up with minor things, but then sometimes they'll come up with like this. I've been having this chesty cough for the last 2 days. And I've not yet started I've spoken to the GP, but he has not yet given me an appointment to, to see whether I need antibiotics.
Right.
That kind of thing.
Right.
But I'd rather know even the smallest detail than not know about it.
That is true. But then are there any kind of age, as you said, there is an aging population. So are there anything that, beyond a certain age, these investigations or these are absolutely mandatory? Or for younger population, you may not ask so many.
Look, a 42-year-old who has had a heart attack in the past and has had a CABG and has not had an echo, I will ask for an echo.
Absolutely.
An 80-year-old who's got a bit of high blood pressure, ECG looks okay, little bit of right bundle branch block, etc.
You will not.
Ask.
So again, there it is tailored to the person. So the
80-year-old who can walk, who walks his dog for 1 mile every day, I won't ask for an echo.
Right. Okay. So the history also will suggest to you what kind of investigations.
Is the important thing, na?
Right.
Anything small also they need to tell me.
Right. Mainly again, that's why I'm trying to understand that it's mainly the history which will tell you what investigations to do, and based on that you will again then assess the patient whether the person is.
And normally, this is what I said. The way things have progressed, at least in our trust. This pre-op assessment, they pick up this. The nurses pick it up. They refer to a pre-op anesthetic consultant who deals with that specialty.
Right.
Okay?
Right.
So my colleague in neuro anesthesia, for example, will see that patient because the nurse has saying something has come up.
Right.
He will prescribe okay, this patient needs an echo.
Right.
This patient needs a pulmonary function test.
Right.
Okay, this one has got arrhythmias, he needs a 24-hour ECG.
Right.
So these things are then done, and then the patient is re-seen by the same or one of the.
Right.
And then I get him as the fourth level.
Right.
So I've got everything on that computer when it works.
Right.
Or if your password works. Like I came back from holiday after a month. Sure enough, invalid password. Please change. There you go.
It's fine as long as you don't have to put a patient to sleep before that.
No way, I won't do it.
Exactly.
I will not do it.
Obviously.
End of story.
Of course. Just joking. Right. So, Sunita, I mean, what we know or what I have heard is chronic pain management also comes under the purview of anesthesiologists. I mean, nowadays. So, how does that generally work?
Like I mentioned before, anesthesia has become very specialized. There
Right.
are different specialties.
Right.
Now, pain management, unlike intensive care, you have A&E physicians, you have respiratory physicians who have become intensivists.
Right.
Okay?
Right.
They have not done anesthesia, they've trained in those specialties.
Right.
Whereas in chronic pain, it's still very, very, very much anesthetists who deal with it.
Right.
Having said that, like I said, everyone goes into a specialty. The pain people, they tend to concentrate only on pain.
Right.
They do a lot of work. They also, to be very frank, generate a whole lot of revenue for the anesthetic departments in all trusts in this country.
Right.
They generate a lot of revenue. Okay?
Right.
But it's done by anesthetists in the majority. In fact, I would say 85%. I don't know anyone who's not an anesthetist who does chronic pain.
Right. But then, I mean, when
Of course, they're supported by psychologists and psychiatrists.
Understood.
Yeah.
Understood. No, but when I'm asking you about chronic pain, I mean, what kind of chronic pains do these people handle?
Everything from top to toe. And they see there's two ways of dealing with chronic pain. Basically, there's two methods of treatment. One is the pharmacological method, okay, which is drugs, and more drugs. The other one is the interventional methods, where you have all these nerve blocks, epidural, facet joint blocks, paravertebral blocks, all the various blocks, which I am not an expert to talk about, to be honest.
Right.
Okay. So that's what they do.
But is cancer pain management done by them?
No, that's mostly palliative care.
That's palliative care.
Not
Okay.
cancer.
Not anesthetist.
Not chronic pain.
That doesn't come under the chronic pain.
No.
So then what comes under chronic pain?
Chronic pain is like, it could be anything. A lot of them are even, it's just all in the head. I'm sorry to say it sounds awful, but some of it, it's a question of listening, and then you decide whether you need to do an intervention or this person just needs,
Or it could be like a post-trauma pain?
Yes.
Okay.
Post-trauma pain, like phantom limb pain. Now, those are dealt with.
Right. So after an amputation.
For example.
Right.
And if they can't deal with it, then they refer back to the surgeons who do the neuroma removal,
right.
whatever they can do. But things like, and chronic pain also manages to a certain extent. I wouldn't say that's chronic pain, that's acute pain, which is again another little specialty which has evolved. Is like we give anesthesia, we make sure the patient's comfortable post-operatively. We prescribe drugs for them to have on the ward when they go back to the ward. However, some of them, especially the major abdominal stuff, they have these epidurals put in for post-operative pain relief. That's all handled by the acute pain management team, which is again anesthetist.
Anesthetist again.
It's
under the anesthesia.
Yeah.
All right. So now let's come to some of the myths which you come across when from patients, some questions you feel that,
Okay, the two most common ones I get is, will I wake up? I've mentioned this before.
Right.
Will I wake up? So
genuine question, like, people get scared that.
That's one. Second thing is, I had a friend who had this surgery and they were awake right through. That's awareness. Okay.
Right.
So then you need to.
With certain surgeries, you do need that awareness throughout the surgery, where you sedate them if they are anxious.
Sedation is different because when you sedate someone, you tell them, I'm not knocking you out.
No, I'm trying to tell you, something like, recently, as I was telling you, I went through an angiography. So
yes.
Process, and it could have been an angioplasty if needed, but that's a procedure. But still, I was not put under, sedation.
Now, if you were very anxious, the surgeon or the interventionalist would have asked, can we have some sedation because she's rather anxious. Like when they do, esophagoscopies.
Right.
Endoscopies.
Endoscopies.
Yeah.
Right.
But then again, it comes under the remit of the anesthetist.
Exactly. That's
You
what.
know,
So that is the main myth which people have. Like, they're scared
They're
that
scared.
they may not come out of anesthesia.
The only way you ask them, at least I do, what are you scared about?
Right.
This is the answers which come. One, that I will know what's going on, and two, that I won't wake up. These are the commonest
Most
ones.
common ones.
Frankly, these are the only two ones.
Right. So any unusual questions a patient has ever asked you?
Oh, there's so many, Sabu. Oh my God. Sometimes you have to, smother a laugh and just keep a straight face and answer.
But have asked you about the procedure of the surgery?
They do.
They do?
They all do. But what exactly? Oh, like I said, are you a doctor?
Oh my God.
Also, a very common question, are you going to be doing the surgery? I'm
Right.
like, no.
Right.
I'm putting you to sleep. I'm keeping you safe when you're sleeping, and I'm waking you up. And I'm making sure that you're pain-free after surgery.
Right.
Okay?
Right.
So whatever it is that you need to ask the surgeon, he will be coming to see you to get your consent form signed. He will explain everything to you, and you need to ask him what he's going to do, how long you're going to be in hospital, etc.
All the questions, all the queries which they have.
This happens all the time. Are you doing the surgery, and what are they going to do?
Right. 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 Great. Sunita, so till now we have, you have been talking as Dr. Sunita.
Yes.
From the brain.
Yeah.
Now we want to know how Sunita talks from her heart.
Okay.
Okay, so I'm going to give some questions which have got nothing to do with medicine.
Brilliant. No problem with that.
And let's see what answers you have there. So the first question is, you have mastered the art of putting people to sleep.
Yes.
Right? But what's your secret to stay awake during boring meetings?
I'm not a management person, Sagu. I tried it, didn't like it.
Right.
Give me a patient to put to sleep. One of the reasons I took anesthesia is I don't have to talk
Right.
to patients. They come in, I've done all the talking before, fatak se, they're asleep.
Right. Perfect. So, do you use your calm anesthesia voice to win real life arguments?
Never. I don't know, Sago, you know me. Patients, it's a different persona. It's Dr. Pillai.
Right.
Okay?
Right.
With family and friends, like you, for example, it is Sunita or Sunu.
Yes.
Okay?
And they are got two complete different personalities and totally opposite personalities.
Yeah. You can't even bring the two together.
Right.
So my sister, for example, she says, how are you a doctor?
I know you for the last 40 years.
Yes.
Yes, of course. Right. So, what's the funniest thing a patient has said to you while waking up from anesthesia? Anything which is funny or heartwarming?
Heartwarming, I can tell you.
Right.
Very recently, old man, he was having some brain tumor taken out and whatever, and he was fortunately one of those, you know what you're doing, you do it.
Right.
Okay?
Right.
Lovely, lovely man, big fat fellow, intubation difficult, oh bakre, so the sweetest thing, I woke him up, it was a long surgery, I think it was 11, 12 hours totally.
Mm-hmm.
Woke him up. This was very sweet. He woke up beautifully, okay, and he just said, can you come? I was standing at the head end of the bed because that's where the anesthetist is. So he says, can you come here, sweetheart? And he just literally got, the bed was propped up, obviously. Right. He just gave me a hug and kisses on the face. And he said, do you know, if I was 40 years younger,
right,
you would be my wife. This after 11-hour anesthesia kid.
How sweet.
Trust me, Sago, anesthetists, we go the next day and see the patient, they're doing all right, they're not in pain, all vitals fine.
True.
This man, I went and saw him for 5 days, he was in the hospital. Every day I used to go, somehow take the time out, go and sit and have a chat with him. He would hold my hand, give me a hug, He must have been, 83, 82, 83, somewhere there.
Such a nice feeling, nah? It's a beautiful feeling.
It doesn't come often with anesthetists because I always say this, and I think you should mention this. If you're a good anesthetist, your patient will not remember you.
That's going to be your tagline.
If you've done your job properly as an anesthetist, they're not going to remember you. And then you've done a good job.
But that's sad.
It is in a way.
But it is in a way great pride of
great. Like I got a little girl. She must have been 8 years old, and small case, some plastic surgery, nail bed repair, something like that. Very minor. So I said, yeah, I'll go and do it. And she made me a drawing and she asked me my name. So I told her Sunita. So she's written and she's put a heart and a little girl and a stethoscope.
Oh my
I put it in my appraisal the following year.
Wow.
You know.
How sweet.
And things like that, they don't happen often for an anesthetist. They don't.
They don't, and that's the reason it's so much more special when it actually happens.
Yes. You know, like surgeons, my husband, every year, Christmas time, 10 bottles of wine will come. 10, forget more than that.
Right. The surgeons take center stage, but equally crucial is your job, to keep how will a surgeon operate unless you take care of the patient first? So that is what people tend to forget.
So that we don't get.
Right. Okay, Sunita, last question. What's your idea of a perfect date?
Perfect date. Perfect date is after all these years. It's reached the stage where we just like to spend time with each other. Holidays. Yeah. Okay. Which he's crazy about. He does all the organizing and then he plans very nice things. Like, I'm a foodie. I love whichever country I go, I like to eat the local food. Nothing else. Right. He will actually find out restaurants. Poor thing is vegetarian. Usko kya milta hai? Fries, French fries. That's all he gets to eat. It's reached a stage where we are friends, man. Like we've always been.
Right. That's the best kind of romance to have.
Yes.
You have being best friends.
Yes. And can talk to him about anything.
Right.
Anything and everything. Moan, groan, and as you know, my temper, everything.
So great, yeah, Sunita. This has been extremely fun, but also an enlightening conversation.
I hope so.
Yeah.
I've said the minimum that I can, that everyone understands. No, but great talking to you.
Oh,
and I'm so happy to have you here, Sunita. Thanks, Salo. Thanks.
Thank you. I hope today's talk has helped demystify the crucial role an anesthetist plays as they ensure the safety during some of your life's most vulnerable moments. If you are scheduled for a procedure, don't hesitate to ask questions to your anesthesiologist. They will help you understand and see to it that your safety is taken care of during one of the most vulnerable times of your life.
Thank you for tuning into today's episode. If you enjoyed the conversation and found it helpful, be sure to subscribe to The Health Talk with Dr. Sagorika Mullick for more such insightful discussions. You can follow us on Instagram, and remember, you can also catch this episode on Spotify or your favorite podcast app. The links are provided in the description. We would love to hear from you, as your feedback will help us to bring you the topics that matter most to you and your family. So until next time, stay informed and stay healthy, one episode at a time. And don't forget to like, subscribe and share this episode. Your health journey starts here.